Good morning. Thanks for your patience. Thanks so much for coming. I'm Tom Boyke. I'm the director of the Global Health Program here at the Council on Foreign Relations. It is my pleasure to welcome you this morning to this session on what's next in global health. So the last 2 weeks have thrown the global health sector into disarray. That started with the first day in which President Trump, his inauguration, he withdrew from the World Health Organization, the World Health Agency, and did so in a manner that he purported to revive the withdrawal notice from 2021, suggesting the intention is for that withdrawal to be effective immediately. That same day, a 90-day executive order was issued implementing a 90-day review of all U.S. foreign assistance that was subsequently interpreted as a stop work order, both on existing and future aid funding projects, and then led to an effort to put on administrative leave much of USAID staff and to call back many of the 10,000 USAID staff who are located abroad. That is subsequently, and many of aspects of this has been subject to litigation. A temporary restraining order was put in by the DC District Court around the effort to slash USAID from 10,000 people to 600 people. That order lasts until tomorrow, I believe, in which case it will be then litigated further. In the meantime, a waiver has been issued for humanitarian assistance and essential medicines, but given by Secretary of State Marco Rubio, but given the limited staffing, the need to apply for specific waivers for specific programs, and broader confusion from all these changes happening, that has led to a halt or a pause of many U.S. Global health programs, most notably the PEPFAR program, which provides life-saving treatment to 20 million individuals living with HIV/AIDS worldwide. Even if these litigation is successful, it is hard to imagine the broader relationships, whether it's around the World Health Organization, around USAID, returning to the state that they had been just 3 weeks ago. Moving forward, particularly after a point where the president and some of his senior staff have called USAID a criminal organization that must be shut down and put into a wood chipper. And as they say on late night TV infomercials, but wait, there's more. There was also last Friday, after hours, a executive action taken to restrict the indirect support that comes with NIH grants to 15%, which on average would cut in half the support that academic institutions receive for research and the research and development ecosystem that supports health both here and abroad. So in thinking about what comes next, we're going to try to have a forward-looking conversation, less about debating the merits of the actions that have been taken, and more about what this means in the near and medium term, and how these organizations are trying to adjust, and where there's possibilities of partnerships to help mitigate some of the actions that have been taken. We have a perfect set of speakers to help us engage through these discussions. You have their bios, so I'm going to ruthlessly truncate them. To my far right, we have Anil Soni, who is the CEO of the World Health Organization Foundation. Prior to joining the World Health Organization Foundation, he was the head of global infectious diseases at Viatris and the CEO of the Clinton Health Access Initiative. To my immediate right, we have Ambassador Isabel Coleman, who most recently served as the Deputy Administrator of USAID. Formerly, she was Chief Operating Officer at Give Directly and has served in a variety of roles in the Obama administration at the United Nations. And of course, near and dear to my heart, is a former senior fellow here at the Council on Foreign Relations, and it's wonderful to see her again. Megan Rainey, in the middle, is the Dean of Yale School of Public Health and the C.A. Winslow Professor of Public Health, and comes to that role from Brown University, where she had also been the Dean of Academics at the School of Public Health. I'm hoping I'm getting that right. We will have a 30-minute conversation about the implications of what we're facing, and then turn it to a Q&A with the audience. Please be aware that this meeting will be on the record, and we will post the transcripts and the video online afterwards. So I want to go through this with the group and talk a bit about the practical implications in the near and medium term for the organizations you are currently affiliated with or used to be affiliated with most recently. What are the implications of the U.S. administration's actions on global health on your operations? Why don't we start with Anil?
Sure. So I'm going to talk about the implications at the World Health Organization in just a moment, and the foundation works on behalf of the WHO to mobilize funding and private sector partnership. But the most significant implication, which I think is incredibly important to start with in any of these conversations, is on communities of people who are served by our organizations. And so this is not an exaggeration to say that millions of people today do not have access to medicine, to food, who have been disenrolled from clinical trials where they were getting high-quality medical care. That has happened already in the last 3 weeks. At the World Health Organization, what this means in particular, there's two aspects to the announced withdrawal. And both of these are different than the first Trump administration. As people in this room will recall, when President Trump was last in office, there was an announcement of a withdrawal that has a year-long notification period. During that period, prior to the end of that term, there was ongoing scientific collaboration and ongoing funding to WHO. That is not the case in this instance. As of the day of the executive order, 3.5 weeks ago, there is no contact between the World Health Organization and colleagues at the CDC, the FDA, the NIH. There is no contact whatsoever. What that means is that information that is typically shared, for example, about disease outbreaks, whether Ebola on the continent of Africa, whether avian flu here, that information is not being shared. And that is limiting the ability of both international organizations and American organizations to respond to outbreaks. That's already happened. That is an aspect of the U.S. withdrawal that is deeply concerning independently of the funding. So what we hope at the World Health Organization is that there will be a political process to ensure that the United States does not withdraw, because that would have ongoing negative repercussions for both Americans and the world, given that scientific collaboration. In terms of the funding, the United States is the largest donor to the World Health Organization and provides roughly $500 million per year, which is 18% of the budget. That funding has not only stopped for 2025, but also for 2024. The U.S. typically pays its contributions to the WHO at the end of the year, even early into the following year, but the WHO has already spent that money with agreement with the United States government historically. There's an allocation, the WHO spends it, that money is received later, they manage cash flow accordingly. The WHO has not received and does not expect to receive funding from the United States for 2024 or for 2025 onwards. The particular programs affected are the emergencies program, so the ability of the WHO to respond to health emergencies and natural disasters. 60 to 70% of the World Health Organization's programs on HIV and TB are funded by the United States. That funding has already stopped. Hundreds of staff have been terminated. And for vaccination, particularly polio and measles. Given the other speakers, I'll stop there, but those are the specific programs at the WHO that have been halted, and what the WHO is doing is now effectively planning a major budget reduction because there's not an expectation that the funding would return.
Great. A couple of follow-ups just to draw that out that I think are clear from your statement, but just to make sure that's the case. In terms of participation in agreements that the U.S. has entered into, like the Pandemic Influenza Preparedness Framework, or the international health regulations, or its membership in ongoing networks, like the ones that you mentioned on global avian or global influenza, has the administration taken, as far as you know, or communicated to WHO that it is withdrawn from either those agreements or those networks moving forward?
Thus far, their participation, again, we're 4 weeks in, less than 4 weeks in. Thus far, the participation has halted. There has not been a communication as to what will happen later in the year, but thus far the communication, the participation is halted, and the hope at WHO is that there will be ongoing engagement. The United States did send a delegation to its executive board meeting. They were staff members who were there largely as observers. They were not political appointees. But in terms of the specific agreements and frameworks of collaboration that you mentioned, in the last 4 weeks, there has not been participation. Whether or not there is in the future, we will wait and see and hope there will be, but as of now, that's not the expectation.
Great, thank you. Isabel.
Well, Tom, I will answer your question really as most recently a U.S. diplomat and a member of our National Security Council. Yes, I was the Deputy Administrator of USAID, but I think at this moment that is somewhat irrelevant because USAID is not coming back. But you know, from a national security perspective and also from just a global perspective, I think the easy way to describe what has happened from a global health perspective is that the leadership role that the United States has played in extending global life expectancy is finished. So the United States has been a leader in so many different realms, from reducing maternal mortality, child mortality, increasing access to vaccines around the world. Anil talked about PEPFAR and HIV. I mean, in so many different ways, but it has really served to extend global life expectancy. And COVID set back global life expectancy, and we've seen it returning to pre-COVID levels, but not fully and not in every country. And I think the removal of US leadership is going to deal a massive blow to the entire sector. It is about a third of funding for the entire global health sector around the world. And you know, the parts of it will be made up in one way or another. Some other rich donor countries will step in and do a little bit of it. Some private foundations may do a bit of it. Some non-traditional donors, you know, maybe the Gulf countries will step up, will do a bit more. But at the end of the day, this is a massive whole, and there's going to be global triage in global health. So things that we have been investing in over the years are going to just grind to a halt. And I think that emergency response will continue, but a lot of the other investments that have been made in strengthening global health systems will not. And the countries that have been quite dependent on foreign assistance for their global, for their health systems are going to either have to turn to more domestic resource mobilization to make up those gaps themselves. And you'll see some countries able to do that. And some countries have already started on that path. You know, South Africa, for example, has picked up, I'm sure one of you know this statistic better than I, but I think it's about 70 to 80% now of their HIV spending in their country. Kenya, another country, you know, have made strides on taking on more of their own health burden. But there are a lot of countries that aren't going to be able to do that. And they're going to, you know, turn to any place that they can. And you will see, I think, over the long term, you're going to see a reduction in, Anil already mentioned it, research that's going on at American universities, and also the reach that our pharmaceutical industry, which is a huge export sector in America, has around the world. And I think you'll see countries buying more cheap generics from China, whatever they can get. You will see the Chinese, taking much more of a role in global health, generally, but specifically in Africa, and a lot of the countries in Africa, I think, will become even more dependent on China.
Great. Isabel will hopefully correct me if I'm misrepresenting, but some numbers for the audience I think are helpful here. That USAID represents 73% of U.S. bilateral global health spending. That's $6.2 billion of the $8.5 billion overall. U.S. development assistance for health for many countries in East Africa represents between 20 and 45% of overall health spending, and 10 to 20% of overall health spending in West Africa nations. I want to ask you about one thing that you started with as a follow-up, where you said USAID is not coming back. And I want to get your sense of what that means. So we're in the midst of a variety of court litigations happening. So far, some but not all have resulted in temporary restraining orders, particularly around the actions taken against staff, but there's litigation going on around some of the funding commitments USAID has made as well. Let's stipulate, for the sake of argument, some of those are successful. Does that result in, how do you foresee this going when you say USAID is not coming back? Does that result in those programs going to state, or those programs overall disappearing?
Let me clarify. What I meant to say is USAID is not coming back in the way that it was before. So could some of the programs end up moving to state? Look, that's been a topic of discussion for decades now, with some rationale for moving certain programs to the State Department. I don't think this is the way pretty much anyone envisioned it happening. I think what you're seeing, whether it's in a couple of months or in a year or in 18 months, I mean, these court cases are going to take a long time in the system. You are seeing the infrastructure of global health grinding to a halt. And not just global health, but global development. You were seeing major partners where USAID was funding, in some cases, 30, 40% of all of their activities, shedding their staff, canceling contracts. It is a set of actions that are going to leave the entire global health and global development world within months in a completely, profoundly different way. And there's also, with global health, you've seen a massive a break in trust. I mean, a lot of people, I mean, what does the U.S. represent to people around the world? In so many countries, the focal point, the touch point is global health. It's healthcare. They know that they're getting their antiretroviral drugs, their children immunized, therapeutic food, whatever it may be, it's ground to a halt. And that trust deficit, I think, will take a generation to restore.
Great. Speaking of generational level change, to the research and development ecosystem, the policy announcement by the NIH around indirects could be quite significant. Can you talk a little bit about how academic institutions like yours, Megan, are thinking about this transition? And then feel free, as part of that answer, to talk a little bit about the disruption at WHO and USAID and how it affects academic institutions as well.
Absolutely. Thank you, Tom, and it's lovely to be here. I should say as I start, I'm not just a dean and a researcher. I'm also a practicing emergency physician and a returned Peace Corps volunteer. So I have multiple perspectives on global health. I'll talk in terms of the science, the healthcare, but also the education and that kind of generational effect that you mentioned, Isabel. In terms of the very short-term effects of what's happened over the past few weeks, we at Yale, as well as at other institutions across the United States, have received stop work orders on a number of our projects that were funded by USAID or the State Department. We have other global health projects that were in progress where we have not received new notices of award or where the funding is very much up in air. So we have countless projects, somewhere between 20 and 30% of our total number of grants, that have either had to stop outright or that are being paused. And I'm going to give you a couple of examples. We have a humanitarian research lab that uses satellite as well as on-the-ground data to demonstrate genocide in Sudan, famine in Ukraine, trafficking of children in Ukraine, and much more. Their data has been used by Nick Kristof, by the ICC, by National Security Council, and others. Their funding stopped completely, and I thought that I was going to have to actually disband HRL until a donor stepped up yesterday and is supporting us to keep their work going for at least another couple of months. That is a very tangible, immediate effect of these changes. A second example, one of our faculty has ongoing field work in Ghana, in Senegal, and elsewhere, looking at malaria, TB, dengue, the whole host of kind of field work to look at how disease transmission is changing, looking at the genetics of various viral illnesses, and thinking about how we stay ahead of changes in disease transmission and pathology. They've had to stop their field work. They have folks who they have worked with for decades who are not sure if they are going to keep their paycheck. They have ongoing projects where data is going to be lost. And they have a generation of trainees who is not able to go out in the field, learn these important techniques that will help keep us protected. A third example is around partnerships that we had that were funded by NSF and NASA. Although NIH funding has not completely stopped, USAID, NSF, and NASA funding has stopped. And those partnerships, for example, around the effect of environment on health, have stopped completely. Again, with disruption of longstanding partnerships, but more so with disruption of the science that we use to keep us healthy. So that's one very clear and kind of immediate effect. Life-saving trials where people have to stop getting their meds immediately. We've all read kind of the wonderful reporting of Stephanie Nolan in the Times around some of the HIV prevention trials that have been stopped midstream. A second effect is around that collaboration for surveillance and prediction of emerging pandemics. Obviously, here in the US, we're dealing with H5N1. We would like to be able to share that data and to hear what's happening elsewhere. There's the Ebola cases that have emerged in Sudan and Uganda. It took us as healthcare providers, because of the stop in CDC communication, it was 10 days from the time that the Ebola case was announced by the Ugandan government until we in the United States got a health alert notice that told us to watch out in emergency departments nationwide for people coming from that area of the world with fevers, et cetera. That means that conceivably we could have had, I don't think we have, but we don't know, conceivably we could have had Ebola cases imported into the United States because our healthcare providers were not warned. So and then there's the surveillance and the sharing of genetic data and all the things that Anil talked about. And then the third thing is around the indirects. And I think I know some of you are in academics, many are not. To explain what indirects are, people think of them as some slush fund that somehow is extra for us as research institutions. Basically what they are a contract, a negotiated rate with the federal government that says, instead of putting every cost of research, how much it costs for space, how much it costs to have ethics boards, human subjects review boards, how much it costs for animal care, how much it costs for IT systems, how much it costs to transmit data and keep it. Instead of itemizing each of those costs for each grant, instead we go through this complex negotiation process where the government agrees to basically reimburse us for the vast majority of those costs of doing research in a thing that's called indirects. It's not extra. It is part of the cost of doing research, and in fact, it doesn't even fully cover the costs of research, but it has been separated out from the direct costs of doing the studies because it makes it easier for investigators. It honestly makes it easier for the federal government, and it, of course, makes it easier as we are writing grants to approximate costs. The indirect freeze has been reversed in the 22 states whose AGs were parties to the lawsuit that was filed and that we got a temporary stay on Monday. In other states, that freeze has that 15%, which is a cut of at least half of indirects is continuing. What that means, in the short term, we at universities are going to have to figure out what parts of our infrastructure we no longer support. In the longer term, it's going to mean that some more expensive types of research don't happen. It's going to mean that we're going to have to renegotiate with the federal government to put those costs that we call indirects into the grants themselves. We can't keep labs open. We can't keep human subjects boards employed if we don't cover those infrastructure costs. So we're going to have to figure out a different way of charging. And ultimately, it's going to mean that a lot of really important science that is on the cusp of creating life-saving pharmaceuticals, creating new diagnostic tests, monitoring the emergence of the next life-threatening disease, identifying the effects of chemicals on health, many of those studies are going to stop with then a generational effect because our students get trained by working on others' work. So there's going to be that immediate health effect that we're already experiencing with stop work orders. There's going to be a shift in what types of work we do, and we are going to see potentially a generation of students who don't get trained. So it's not just a generational effect on trust, but also on our ability to participate in surveillance, our ability to participate in emergency response, our ability to participate in the cross-cultural collaboration that we all know is so critical to global health. I'll stop there for now.
Great. So all of this comes at a uniquely lousy time for global health. We are in the midst of a number of organizations looking to replenish, raise money for their activities, including the World Health Organization, Gavi, the Global Vaccine Alliance, the Global Fund to Fight AIDS, TB, and malaria. All these institutions we're in the midst of fundraising campaigns to support their activity. Our friends at the Institute for Health Metrics and Evaluation just put out an analysis of government health spending for the average in sub-Saharan Africa is $92 per person. Their forecast is that that is likely to go down with demographic changes, growing populations in those countries. And is also, many of these governments face significant amounts of post-COVID debt. We are in a number of global crises like Ukraine that are taking resources that might otherwise adapt to this space. So in thinking about, to look to the top title of this session, what's next for global health, we're in an environment where we're thinking about what to triage versus what other sources of support we might look to. And I'd love for each of you to go through and say how the institutions you're affiliated with are looking at new partners or what they might need to triage, and how we're thinking of what might come next in terms of the activities. Why don't we start with you, Anil?
Sure. Well, this word triage has been used a couple of times, and despite Megan's example of a donor coming in and saving one of your programs, at least for a couple of months, I want to be very clear and sober with this audience that we do not expect the funding to be made up by any source. So when you look at possible, and this has been mentioned, what could other governments do? When you look at what's happening in London, Paris, Berlin, you have similar pressures from the political right, and you have reductions in ODA, which are a long-standing trend. There were meetings in Paris last week that confirmed reductions in ODA, not increases despite the actions of the United States. I do not expect there to be substantial increases in funding from G7 or other wealthy nations. We have no evidence that there will be more money from China. That has been a rumor. There has been speculation, particularly relative to the World Health Organization, that China would step up. There is no evidence of that, which isn't to say it won't happen, but there's no evidence. That is entirely speculation at this stage. That's government, at least in terms of donor governments. In terms of implementing governments, those in sub-Saharan Africa and around the world, as you said, they are under tremendous debt burden. I received a question this week in Washington saying, well, what can the multilateral development banks do? Many of these governments are not in a position to take on more debt, and they have limited tax revenue. So do we want them to spend more on health? Of course we do. But are there substantial resources for them to tap into? No. And then there's philanthropy. As far as I am currently aware, major philanthropies that sit on multi-billion-dollar endowments, they are not opening up their endowments and providing substantial new funds over the last few weeks. We do not expect them to. They will, of course, continue to invest philanthropically in their areas of focus, but many of the programs affected may not be in their areas or regions of focus, and we don't see, at least thus far, philanthropic support to be any meaningful bridge back to normal. All of which to say, this is about triage. Programs are going to end, and they are not going to come back. What the World Health Organization has already done is implement austerity measures to slow spending. They have also agreed at its executive board in the last week for its next budget to be reduced by $500 million, which is an annual contribution from the United States. I think that is a starting point, not an end point. I actually think the budget will come down further. And they're initiating a strategic review of what programs to prioritize and which ones to deprioritize. That's good financial management, right? To be clear, if any of you run a P&L in a company, sometimes you have to reduce your costs, but there will be consequences to that. So I'm proud that the WHO is responding with financial prudence, but there's no illusion that the funding is coming back.
Great. Isabel.
I think Anil said it, and I was saying it earlier. This is a massive contraction of the sector, and there's no obvious replacement for it. I mentioned the Gulf countries. I mean, they have a lot of money, but they have a very different conception of what foreign assistance is and how to deliver it. I know I have spent much of my last several years trying to get more money out of counterparts in Gulf countries, and that is not going to be a silver bullet anytime soon. I don't think China is going to come in with money. China doesn't fund international organizations. USAID provided billions and billions to the World Food Program to feed the poor around the world. China provided $34 million. They don't even show up. They're not a player. And you could say, well, maybe they should step up more, but they won't. They don't have the same perspective and outlook on foreign assistance. I could see them coming in and building factories to produce their drugs in certain countries. Some of what we've been trying to do to help local production in South Africa, Ghana, Kenya, other places, you could see more of that, but it's not going to replace the money, and many health organizations are going to disappear. In many of the frontline health organizations, the smaller ones, the ones at the grassroots, at the local level, they are going to be very, very challenged. The big ones will contract, and the smaller ones will disappear.
I'm going to turn to Megan next, but I want to flag for the audience, I'm going to call on you for questions afterwards. So those of you that have them, start thinking of them, and then I will ask you after Megan's intervention. Megan.
Thank you. So I will echo what both of my co-panelists have said, which is that in the short term, we are going to do less work globally, and we should be so lucky as to be able to continue to do work domestically. I think that represents a total elision of the fact that health is inherently global. There are no infectious or non-infectious diseases that respect countries' boundaries or borders, whether we're talking about things like Ebola and COVID, whether we're talking about the effect of social media on health and mis and disinformation, whether we're talking about climate change, the effect of chemical exposures, they are all transmitted across the globe quite quickly. And our lack of global work or non-domestic work is going to hurt Americans' health as well as the health of the globe. And that is the short-term effect of these changes. I think we and others are certainly pursuing those philanthropic relationships. We have them. Most major universities with a global health focus have strong relationships, not just with NIH, NASA, NSF, USAID, but also with most of these major global players, whether it's Gavi, Gates, Wellcome, and so on, but they do not have the capacity to step up. And there are also some concerns about accountability. There are some great large philanthropic organizations, but there are others where their selection process is less than clear, and where the kind of selection of what they invest in may, again, over-prioritize certain problems than others, and may actually result in us having a very lopsided sense of what the major global health problems are. I also worry that this is going, again, I think about my job as an educator, and about the 800 students that we have right now, many of whom want to work not just in the US, but globally. The students below them, the college students who are planning to go into global health. And I'm doing a lot of thinking about how do we reframe this. So I'm then gonna close with a different solution. I'm friends with Wilmot James, who's still at Brown, and I've had a number of conversations with him, with Craig Spencer, who's on the MSF board, and others, about where do we go from here, recognizing that we are heading into a period that is dark and about to get a bit darker. What is the next step? And the best case scenarios that I can see are that we see regional collaborations emerge around both data surveillance and maybe research that we in the US may be able to contribute to and partner to that, but we're not going to lead it. So in some ways, this is the decolonization of global health de facto, because we are no longer providing funding. I think that there is a world in which, yes, some other countries step up a bit more, but I was actually in China the week of inauguration, and the question that I got from my partners at various universities across China was, now what, right? We are partners in the thinking and the science, and for them, looking at us stepping back, it makes them deeply worried. So I agree with you. I don't see this being made up by China, much less by the Gulf states. But I think that we're gonna have to think about new ways of partnership, and the reality is that we're going to lose some of our biomedical and health leadership in the science space. The question is, where does that void get filled, if at all? So that's the kind of scary version of the future.
I'm going to turn it over to the audience. I will call you in the order in which I see your hands. We have about 16 minutes, so if you could state your name and affiliation, make your question sound like a question, and only ask one. That would be great. Gerard first, please.
Good morning, everybody. Tom, thank you very much. Gerard Radivosian, Yale University, formerly Chief of Staff at PEPFAR as well. Megan, I want to follow up on your last comment, which really animated me to ask this question. I'm an optimist. I like to think of every crisis can be an opportunity. And I'm curious if each of you could share from your respective perspectives what opportunities either to drive new reforms that we've been talking about for so many years, new kinds of partnerships, more involvement from the private sector perhaps. I'd love to know what you are looking at as a moment of opportunity during this difficult time period. Thank you again.
Great. Before we answer, there was a huge wave of hands, so I want to take questions in two so we can hopefully get to as many as possible. And this woman here in the sweater was next.
Hi, good morning. Mandy Helford. I'm a professor at Hunter College at the University of New York and the American Museum of Natural History. This has been a fantastic panel. I did my training at Rockefeller with Dan here. And so it's been a major impact, this 15% indirect cost. And I was hoping, Megan, perhaps you'll talk to what it means for training the next generation of scientists. And you mentioned at the end, losing our edge as leaders in science and technology and biomedicine, and that's exactly what's happening. And so a lot of medical school training is on what we call soft money. And so I'd like you to just describe a little bit more, because I don't think the general public is aware of how we train our scientists and our medical doctors. And a lot of that comes from federal support.
Great. Thank you. So I'm going to ask Anil and Isabel to answer Gerard's question about opportunities, and Megan maybe answer the question about training.
Sure.
Anil, do you want to go first?
Sure, I'll try to speak quickly so we can get to more questions. we aren't going to come back. And so even in our optimism or our resilience, I should say, I think we should be clear, how do we mitigate harm? And in terms of the opportunity in the short term, I'll ask a question to everyone in this audience, which is, how can you use your voice to ensure that there is broader appreciation and understanding for the relevance of global health and development to America? This is an America First administration and Congress. These cuts are going to affect American companies. They will affect Americans. They will affect America's place in the world. And those in this room and those who are watching this have privilege and power. And to the extent that you can use that voice, I think this is an opportunity for stakeholders across this country to say, no, this matters to us. It matters to us in terms of our business. It matters to us in terms of our health. It matters to us in terms of our values. And so that's a request, but also, I think, an opportunity. Because I think we've gotten used to the success, that there's bipartisan support for this. We haven't used this is not the 1980s. This is not the turn of the century where HIV activists demanded that more. But we can demand that we still do more if we use that voice. Secondly, I think there's opportunity in terms of the efficiency of the global health and development infrastructure. It is going to be hit. I mean, Isabel has made that clear. So what are we going to rebuild from the ashes? Is it going to be a proliferation of organizations as we have currently, or can there be consolidation, what in the private sector we call mergers and acquisitions? I think there can be more efficiency in the system. And lastly, what I hope is an opportunity, despite my heart wrench that we are abandoning people in country, is that in country there will be more resilience of governments and leaders in low and middle income countries committing to their own programs that have historically been funded by the United States.
Isabel.
I agree with much of that. I think that, Jared, I'm also an optimist, and I think that the sector will be resilient over the long term, because it has to be, because it is critically important, and because people will understand those connections and understand that we are safer and healthier and more economically prosperous when the rest of the world is healthy. And when you look at the cost of having a whole generation malnourished, unvaccinated, it's incalculable. I mean, it's just so huge. And the lost economic opportunity is so massive. And I think that you will see countries stepping up. And there are countries that are on the verge of being able to do more of that, and this will speed up that process. And you will see countries wringing out corruption in this sector. I mean, from a USAID perspective, global health is the area we saw the most corruption, because it's commodities, and commodities get siphoned off and stolen. And that is where we found our own, in our own chains, in our own supply chains. It is in global health that it showed up the most. And I think that there are more efficient ways to do global health, certainly not going through all of these intermediary organizations, but going directly to governments, providing them with funding to really invest in their own health systems, their own people. But USAID has not been able to do that in a majority of countries because of corruption. And if they can't meet, very high fiduciary standards and transparency metrics that we have in place, despite what you're all reading in the press, it's very, very strict. And if they can't meet that, then we cannot go directly through government. We have to go through other organizations. That is inefficient. We know that. And so now it's going to be clear. You either clean up your own sector and there's more transparency, more accountability, or you don't get any money. And there will be efficiencies wrung out of it. We have been a little bit of a victim of our own success in some ways, because we have been able to make huge investments in global health around the world. And now those are coming to a halt, and we're going to have to be much more innovative, creative, and efficient, using new technologies, using new processes, all of these things, to get back to where we are today, and to move forward much further. I think a lot of ground will be lost, unfortunately. In the meantime, we're going to lose ground, but I am an optimist that we will eventually get back.
Megan?
Yeah, totally with you both. I will not go further on that question because I think they did such a great job answering it. In terms of the effect on training, on the effect of the indirect cuts on training. So to be clear, indirects do not support students directly. They're not allowed to. They don't support tuition. They don't support financial aid. So the effect of the indirect cuts on there are other sources of federal funding that directly support students, but not indirects. The effect of the cuts of indirects on future training of scientists is twofold. First is, like the WHO, every university has a P&L. When you have a major source of revenue that supports core functions cut, you then have to think about what gets cut to fill that need, to fill that hole. And is it that we cut the financial aid that we provide to students in order to continue the infrastructure, right? That is a choice that we may make. Or do we keep our financial aid and cut infrastructure, in which case it means there's less research going on, which then means there's fewer training opportunities for the students. So there's going to be a weighing, again, a triage of what things we as universities invest in. There are also some universities and some training programs that will simply close. I'm not going to mince words, right? They may not have pots of money to kind of move around. They may not even be able to make the choice of, I will reduce financial aid in order to support infrastructure. And then if you don't have the infrastructure, you cannot do the research. So there may be universities and training programs that close entirely. And then relatedly, there's going to be fewer paths for those students going forwards in terms of faculty slots, in terms of opportunities to pursue grants, in terms of opportunities for them to take their training and go out into the field. So there will be a ripple effect of those indirect cuts. I do think, to close on the optimism question, where the opportunity may lie, a lot of the money that we spend from indirects is on compliance, right? Whether it's human subjects compliance or accounting compliance, and to your point about bureaucracy, I think there may be efficiencies which may result in more waste or fraud, but may also save us money. And again, so thinking about how do we kind of redefine what we use indirects for, and pushing on the government around some of those regulations that do take a ton of time and money, both by investigators, by students, and by universities. And then the very hopeful thing is that thinking about how maybe some of our students will use this as a chance to redefine global health. I came of age, right, in the age of Paul Farmer and Jim Kim, and Jonathan Mann was an early kind of mentor of mine. And I think about how that generation shaped the way that all of us in this room think about our work in global health. I think those of us in this room are going to have to step up and reshape how we think about it for this current generation of trainees, but also some of them are going to be the ones that create that new version and vision of how we deliver this work, how we continue the research, how we continue to protect the health of folks both in America and abroad going forwards.
Great. We have 7 minutes. I'm going to take a group of 3 questions. Please keep them short, and then we'll have our audience answer. Mitchell, Sierra, and then the gentleman over there.
Great, thank you so much. I'm Mitchell Warren from AVAC, the AIDS Vaccine Advocacy Coalition. I was once an optimist, and I hope to come back to being an optimist. There was also a time in which public health and global health were bipartisan issues, and I'm struck by how it clearly is now not. And I'm wondering, for those of us in a certain global health bubble, we hear and are living what you're describing, and you 3 have been just remarkable in your comments. What's the message to conservatives, to Republicans, that we can get them back? Because I'm struck that many of them were some of our biggest proponents. Of course, PEPFAR is the best example with President Bush. But what would we say to them?
Great. Sure.
Good morning. Sarah Madad, Chief Biopreparedness Officer at New York City Health and Hospitals. I'm also a board member for an organization called Project Hope that operates in 40 countries around the world. I want to bring the conversation to global health and the nexus of national security. I was actually on a call this morning with a congressman, and one of the things we mentioned is that Project Hope has been operating, for example, in Lebanon, and now that they have to pause their services, they're seeing Hezbollah come in and now take over those social services. That's exactly what they do to win hearts and minds. So just curious of where you see the nexus of, global health and obviously the impact it's having on aid, but also national security.
Great. Gentleman over there.
Hi, I'm Aaron Mertz. I'm at the Aspen Institute Science and Society program. Building on what Megan just said, how would you personally convince a very promising undergraduate or early graduate student to stay in this line of education and future hopeful work?
Great. So I may suggest, why don't we go down the line and you can answer which of those questions you can, but obviously, Anil, you're in the role of trying to pitch across a broad political spectrum now in terms of continued funding for WHO. Isabel, you were just on the Deputies Committee at the National Security Council, can think a lot about the national security. And Megan, you have quite a bit to say on the next generation, how we can attract them. But why don't we start with Anil?
Well, I think I'm going to connect the first two questions. I think support for global health is still bipartisan. I think the question is, how do you give it more political capital? We have to sharpen our pencils and be very compelling about the return on investment for health and development in terms of security, in terms of profit for companies, in terms of egg and milk prices. That was an interesting conversation that I had this week. How does WHO affect egg and milk prices? So making the investments in health and development relevant for the current political calculus, whether Republican or Democrat, because it's both. The degree to which we haven't seen support from Democrats on the Hill has been sobering, but they have the political fights that are occurring now, the competition for attention, breaking through the noise and the disinformation. That's no easy task for any elected representative. So is there still bipartisan support in the hearts and minds of people who have been committed to these programs for 25 years? Yes, but we have to give them the ammunition for this to have political relevance in America today.
Isabel?
I was actually going to say exactly the same thing, which is that there is still bipartisan support for global health. I think we're living in a very unique moment right now where there's so much froth, there's so much churn, and it is, the politics are overwhelming the moment. But there are conversations going on within the State Department right now about what is going to be kept of USAID and what is not. And it's a very sad conversation in so many ways because it doesn't understand the reality of the dissolution that's happened, and the fact that organizations are shutting down, laying off people as they are debating this. But you have, I think, a strong sense that they want to keep a lot of the global health. They want to keep the humanitarian and the global health, but they don't know how to do it in the context of what they have unleashed. And you've seen, it's been reported on in the press, ambassadors from all over Africa writing to Secretary Rubio saying, you shut down global health, PEPFAR in particular. We have nothing to offer in these small African countries. The budget is global health. I mean, the USAID budget is all global health in many different sub-Saharan African countries. That's it. I mean, there's a little of this and a little of that, but it's really 90+% global health. And you have ambassadors saying, that's what I have. And are we walking away from the continent of Africa from a national security perspective? Is that what we're trying to do? And that, I don't think, is the goal. There is a bipartisan consensus that global health is important, but now they don't know how to, from the wreckage to keep the parts that they want to keep, and it will be interesting to see how that plays out.
I'll add just a teeny bit on the national security side, which I think answers in many ways Mitch's question. It's not just national security, yes, in terms of groups like Hezbollah stepping in to provide the aid. It's also national security in terms of security against disease. We have a lot of concerns about biopathogens either being manufactured or harnessed or kind of gathered and then spread. So there are real security risks to people in the United States from our lack of involvement in active monitoring, data sharing, and delivery of care. And I think that that is something also. From the pessimist side, we are going to have to see harm, perhaps, not just across the globe, but in the United States. But from the optimist side, I think that that security argument is actually the one that may be most powerful, which then goes to students and how to encourage them to enter the field. I mean, my first thing is it matters more than ever. The second is, by the time you're done with your training, the world will have changed again. And so if this is something that you care about, please enter this now. We need you more than ever. You have the chance to become a leader. And by the time you are done with your schooling, the world will have changed. And so I can't predict for you today what job opportunities there will be, but I can guarantee that it will be better to be graduating with a focus in global health 2 years or 4 years or 6 years from now than it is right today. And then the third part is that this is a chance to lead. This is a blue ocean moment. This is a chance to rebuild, to define the future. And so we need the best and brightest to go into this field, perhaps to get a more complex set of training. And again, this is where the optimist in me says, we've been talking for a long time about we were tropical medicine and hygiene, and then we were international health, and then we became global health. And so maybe now it's a chance to do something different. One of the reasons that I took the job as dean at the Yale School of Public Health rather than going elsewhere is because at Yale, my students do take classes at the Jackson School, at the Divinity School, at the School of Architecture. I think that multidisciplinary training for folks entering global health, but also the exposure of future professionals in other disciplines to the world of health and the way that we think about health problems, that is part of the essential focus for the future. And so I think students entering now can be at that vanguard of thinking differently about what type of training they get and then what jobs they can go into.
Great. I think that's a good note to end on. I'm sorry I couldn't get to everybody in the room. If you do have questions, I hope you'll approach the speakers afterwards. From the council's perspective, this question of how and whether the global health can have a second act is certainly occupying our time, and we remain quite committed to this space and looking forward to working with all of you on those questions. I hope you'll join me in thanking our speakers today.